Welcome to Lesson 1 of your Intrapartum unit. In this lesson, we will cover the concepts of the labor and birth process. Objectives for this unit include: explain the five major factors that affect the labor process, describe the anatomic structure of the bony pelvis, explain the significance of size and position of the fetal head during labor and birth, summarize the cardinal fetal movements of the mechanism of labor for a vertex presentation, to examine the maternal and anatomic and physiologic adaptations to labor, to describe the factors thought to contribute to the onset of labor, and to describe fetal adaptations to labor. The factors affecting labor. At least 5 factors affect the process of labor and birth. The 5 P's: passenger, fetus and placenta; passageway, birth canal; powers, contractions; position of the mother; and psychologic response. First, we'll discuss the passenger. The passenger in the process of birth is the fetus. There are several factors that affect the movement of the passenger or fetus through the birth canal, including the size of the fetal head, fetal position, fetal lie, fetal attitude, and fetal presentation. In this slide, you see the fetal head. The fetal skull is comprised of several bones. The bones are united by sutures. You see the fetal bones here: the parietal bone, the frontal bone, and the occipital bone. You also see the fetal sutures: the lambdoid suture, the sagittal suture, and the frontal suture. The fontanelles are membrane-filled spaces between the bones of the fetal skull that allow for molding as the fetal head passes through the birth canal. The anterior fontanelle is a diamond-shaped structure at the front of the fetal head. And here you see the diamond-shaped anterior fontanelle. This fontanelle is generally 3 centimeters by 2 centimeters. It closes by 18 months after birth. The posterior fontanelle is this triangular-shaped structure at the back of the fetal skull, or the occiput of the fetal skull. This fontanelle is about 1 centimeters by 2 centimeters and closes 6 to 8 weeks after birth. The location of the sutures and bones of the fetal skull are important in determining the position of the fetal head in the maternal pelvis upon vag exam. Fetal presentation is the part of the fetus that enters the pelvic inlet first and leads through the birth canal. There are 3 main presentations: cephalic presentation, which is head first; breech presentation, which is buttocks, feet, or both first; and shoulder presentation. The presenting part is the part of the fetus that is felt when a vag exam is performed. The most common presenting parts in each presentation are occiput for the cephalic presentation, sacrum for the breech presentation, and scapula and the shoulder presentation. Fetal eye is the relationship of the spine of the fetus to the spine of the mother. There are 2 versions of fetal lie: vertical and transverse or horizontal. In the vertical lie, the fetal spine is in line with the spine of the mother and is seen in breech and cephalic presentations, when the fetal spine is at a right angle to the maternal spine. This is called the transverse lie. Vaginal birth cannot be accomplished in the transverse lie. Fetal attitude is a relation of the fetal body parts to one another. The normal attitude of a fetus in utero is one of flexion, in which the back of the fetus is rounded so the chin is flexed onto the chest. The thighs are flexed on the abdomen and the legs are flexed at the knee. Variations from the normal lie can cause problems during birth. On this slide, you see that the baby's attitude is one of flexion. Fetal position is the relationship of a reference point on the presenting part, either the occiput, sacrum, the menum, which is a chin, or succiput, which is a deflexed vertex, to the 4 quadrants of the mother's pelvis. Documentation of fetal position is accomplished using 3 letters. First is the location of the presenting part in the right or left side of the mother's pelvis. Second is the letter of the presenting part of the fetus. The third letter stands for the location of the presenting part in relation to the anterior or posterior of the mother. In order to do this, the nurse must perform a vaginal exam to locate the presenting part. If the presenting part is the fetal head, the nurse locates the fontanelles to locate the occiput. If the fetal occiput and back are to the right side of the mother and the fetal occiput is to the back of the mother, determined by locating the posterior fontanelle, then the fetal position is right occiput posterior, or ROP. The nurse will also document station and engagement, and we will discuss that later in this presentation. In this slide, you see fetal position in a fetus that is breech presentation. In A, you see the frank breech presentation in which the fetal presenting part is the sacrum. And if you'll notice in this case, the attitude is one of flexion except for the knees. The knees are extended. Okay? In B, you see a single footling breech. The lie is longitudinal or vertical lie. Your presentation is incomplete breech, which is the presenting part is still the sacrum except for flexion. Flexion except for one leg is extended. The other leg is flexed at the hip and knee. In C, you see a complete breech. In a complete breech, you have a longitudinal, your baby spine is still in the same relation to the mother's spine, which is vertical. Then you see breech, where you see the sacrum and feet presenting. The presenting part is the sacrum. The attitude is general flexion. Everything is inflexed, including the knees. In D, you see a shoulder presentation. You see the lie is transverse or horizontal. The fetal spine is directly opposite the relationship of the mother's spine. The presentation is shoulder, the presenting part is a scapula, and the attitude is one of flexion. In this slide, you see the measurements of the diameters of the fetal head at term. The biparietal diameter is most often used to measure diameter of the fetal head. And when you see this, you see the different measurements that you will see. Okay. You will see it documented. When you see biparietal diameter documented, it will be documented as a BPD followed by the measurement. In this slide, you see the head entering the pelvis. On the left, you see the fetal head, and on the right, the normal pelvis with the measurements of the fetal head based on the presenting part entering the pelvis. In A, the vertex presentation, you can plainly see the smallest diameter of the fetal head is entering the pelvis and should be able to pass without difficulty. When you look at this part here and then look at this, you see that there should be no difficulty with this fetus passing through the birth canal. In B, you see a sixiput presentation. In the sixiput presentation, the measurement is 12 centimeters. This white part of the fetal head is entering the pelvis. When you look at the fetal head entering the pelvis here, you plainly see the pelvic bones overlapping the ischial spines. In C, this is the brow presentation. The widest part of the fetal head, which is about 13.5 centimeters at birth, is attempting to enter the pelvis. You can absolutely see that there would be no way that this baby should be able to pass through this pelvis. This is the reason that an attitude of flexion is important. The more extended the fetal head becomes, as in with the brow presentation, the wider the presenting part becomes, making it difficult, if not impossible, to have a vaginal birth. In this slide, you see a picture of the maternal pelvis. This is the way that station can be documented. When performing a vaginal exam, the nurse palpates for the ischial spines. Station is documented by assessing the location of the presenting part in relation to an imaginary line between the ischial spines. It is measured in centimeters above or below the ischial spines. The imaginary line itself, if the presenting part has reached this line, is documented as 0 station. 1 centimeter, 2 centimeters, 3 centimeters above or more above the ischial spines is documented as -1, -2 station. 1 centimeter, 2 centimeters, 3 centimeters or more below the level of the ischial spines, it's documented as a +1 or +2 station, and so forth. Passageway. The passageway consists of the bony pelvis, the cervix, the pelvic floor muscles, the vagina, and the introitus, or external opening of the vagina. While the muscles of the pelvic floor play a role in the birth of the fetus, the bones of the pelvis play a greater role, as the fetus must accommodate itself to fit through a relatively rigid passageway. To review the anatomy of the bony pelvis, you need to go to Chapter 3 in your book. The true pelvis, which is the part involved in birth, is divided into three parts: the inlet or brim, the mid-pelvis or cavity, and the outlet. This shows the maternal pelvis and the different diameters and the different structures of the maternal pelvis. In this slide, you see the different measurements of the pelvis. A is the inlet and mid-plane. So you see the inlet and the mid-plane, and then you see the least dimension of the pelvis as the fetal head moves through the pelvis. B is the cavity of the true pelvis, and C is the curve of the sacrum and the axis of the birth canal. Notice the angle the fetus must travel in order to be born. It must go this down through the pelvis, then curve around where the sacrum, and then out. There are four basic types of pelvis. The gynecoid pelvis, as seen here, is the classic female type of pelvis, and it's also the most common type, being found in 50% of all women. The anthropoid pelvis and android types are less common types of pelvis, with the platyploid pelvis being the least common. Mixed type of pelvis are more common than a pure type. The soft tissues of the passageway include the lower uterine segment, the cervix, the pelvic floor muscles, the vagina, and the introitus. Before labor begins, the uterus is composed of two segments, the uterine body and the cervix. After labor begins, uterine contractions cause the lower uterine segment to gradually distend to accommodate the intrauterine contents, as the wall of the upper segment thickens and reduces its capacity. This causes downward pressure on the fetus, pushing it against the cervix. The cervix thins or effaces and dilates in order to allow the fetal portion to descend into the vagina. The pelvic floor muscles assist the fetus to rotate anteriorly as it passes through the birth canal. In A, you can see a normal uterus. You can see as the uterus stretches and begins to grow. You see the active segment of the uterus, the physiologic retraction ring, and the passive segment, along with the external os. In this section, you see how this begins to thicken, and as it thickens, there's less capacity in here to accommodate the fetus. The muscle then begins to push the baby down into the lower segments of the uterus, and so it can come out through the vagina. As you can see here, the cervix is much thicker. You see as the changes gradually happen, it becomes thinner and thinner until barely any cervix can be felt at all. The powers include both voluntary and involuntary powers. The primary powers are the involuntary powers of uterine contractions that cause effacement and dilation. Once the cervix is dilated, voluntary powers, the bearing down efforts by the mother, are the secondary powers. This slide shows the effect of the primary powers on effacement and dilation. Effacement means the shortening and thinning of the cervix. The cervix is normally 2 to 3 centimeters long and about 1 inch thick. As you can see in diagram A, this cervix is not dilated or effaced. As labor progresses, the cervix is shortened and thinned until only a very thin edge can be palpated once effacement is complete. As you can see in B, you're beginning to see a shortening and a thinning of the cervix. In C, it's becoming even thinner and shorter. Effacement generally occurs before dilation in a first-time pregnancy. However, in subsequent pregnancies, effacement and dilation usually progress at the same rate. Dilation occurs as the cervical opening is widened. The diameter of the cervix increases from 1 centimeter to 10 centimeters, or completely or fully dilated. When you hear the labor nurse say the patient is complete, this means the patient is 10 centimeters or fully dilated and ready to give birth, as you can see in D. Once the cervix has completely dilated and faced, the secondary voluntary powers begin. The mother will get an intense urge to bear down and push. Position affects the woman's anatomic and physiologic adaptations to labor. There are frequent changes in position will help to relieve the fatigue, increase comfort, and improve circulation. The laboring woman should be encouraged to find the position that is most comfortable to her. Labor refers to the process of moving the fetus, placenta, and membranes out of the uterus and through the birth canal. Various changes occur in the woman's reproductive system before labor actually begins. Labor can be discussed through mechanisms in the process and stages that a woman goes through during the process of labor. With first-time pregnancies, the body starts preparing for birth approximately 2 weeks before term as the uterus sinks downward and forward and the presenting part descends into the pelvis. This is known as lightening or dropping. The woman may also experience irregular but strong and frequent uterine contractions known as Braxton Hicks contractions. The vaginal mucus becomes more profuse, which is the result of congestion in the vaginal mucous membranes. Brownish or blood-tinged cervical mucus may be passed, which is called bloody show. The onset of labor can be attributed to a number of factors, including changes in the maternal uterus, cervix, and pituitary gland. Hormones produced by the normal fetal hypothalamus, pituitary, and adrenal cortex probably contribute to the onset of true labor. Many women may feel the Braxton Hicks contractions are true labor. Characteristics of true labor include strong, regular, rhythmic uterine contractions that cause cervical dilation. If the woman can walk and the contractions decrease in intensity, it is likely not true labor. There are 4 stages of labor. The first stage of labor lasts from the onset of regular uterine contractions until full dilation of the cervix. The first stage is longer than the second and third stage of labor combined. The first stage of labor is further divided into the latent phase, the active phase, and the transition phase. During the latent phase, there is more progression and effacement of the cervix and little increase in descent. During the active and transition phases, there is more rapid dilation of the cervix and an increased rate of descent in the presenting part. The second stage lasts from the time of full dilation of the cervix until the birth of the fetus. There are 2 phases, the latent phase and the active pushing phase. During the latent phase, the fetus continues to passively descend through the birth canal and rotate to an anterior position as a result of ongoing uterine contractions. The urge to bear down during this phase is not strong. Some women may not feel it at all. During the active pushing phase, the woman has a strong urge to bear down as the fetus continues to descend and presses on the stretch receptors of the pelvic floor. The third stage of labor lasts from the birth of the fetus until the placenta is delivered. The fourth stage of labor lasts about 2 hours after delivery of the placenta. This is the time when homeostasis is restored. It is during this time that parent-child bonding and attachment begins. This is the time when assessment for complications such as abnormal bleeding takes place. This slide shows the mechanism labor. If you look at A, you see the fetal head. You see in this location, based on the fetal spine, this is the sacrum, and this is the pelvic bone, the symphysis pubis. Here you see the posterior fontanelle. The posterior fontanelle and this baby are to the left side of the mother. The occiput, showing the posterior fontanelle, is to the anterior of the mother. And it's left, occiput, anterior. This is the LOA position. In this LOA position, the fetal head begins to move down, and you see here the location of the fontanelle as it moves down. It's moving even more. You see here it's becoming more flexed right here as it entered, then it's moving even more. It's starting to extend somewhat, and as it extends, it starts to internally rotate, and you see now the posterior fontanelle is directly under the symphysis pubis. Here you see that the fetal head has moved down and has begun to extend as it comes out of the vagina. In E, you see here that the fetal head is once again turned back the way it was here in restitution. And the posterior fontanelle, as you see, is here as it was here. And as you come out, the fetal head turns again till now it's transverse, so it's coming so that the rest of the fetus can be born. The physiologic adaptation of the fetus to labor. The average fetal heart rate is 140 beats per minute. The normal range is 110 to 160 beats per minute. Earlier in pregnancy, the average heart rate is 160 beats per minute at 20 weeks gestation. The rate decreases progressively as the maturing fetus reaches term. Temporary accelerations and slight early decelerations in heart rate can be expected with spontaneous fetal movement, vaginal exam, fundal pressure, uterine contractions, abdominal palpation, and fetal head compression. Fetal circulation is affected by maternal position, uterine contractions, blood pressure, and umbilical cord blood flow. Most fetuses can compensate for the decrease in circulation that occurs during contractions. The umbilical cord usually floats freely in the amniotic fluid. However, it can be compressed, leading to decreases in the fetal heart rate and decreased circulation to the fetus. There are changes in the chemoreceptors in the aorta and carotid bodies immediately after birth. These changes include clearing the fluid from the air passages as the fetus passes through the birth canal, a decrease in fetal oxygen pressure, an increase in the carbon dioxide pressure, a decrease in arterial pH, a decrease in bicarb, a decrease in fetal respiratory movements during labor. As a woman progresses through stages of labor, various body system adaptations cause her to exhibit both objective and subjective symptoms. During each contraction, an average of 400 milliliters of blood is emptied from the uterus into the maternal circulation. By the end of the first stage of labor, cardiac output during contractions is increased by 51% above baseline pregnancy values at term. Cardiac output peaks about 10 to 30 minutes after birth and returns to pre-labor baseline within the first postpartum hour. Both systolic and diastolic blood pressure increase during contractions and return to baseline levels between contractions. Supine hypotension occurs when the ascending vena cava and the descending aorta are compressed. WBC levels can also increase. Hyperventilation may cause respiratory alkalosis, hypoxia, and hypocapnia. In the unmedicated woman, oxygen consumption almost doubles in the second stage of labor. Voiding may be difficult during labor because of tissue edema, discomfort, analgesia, and embarrassment. Proteinuria of 1 plus is normal during labor. Integumentary changes are evident due to the stretching of the perineum. Despite the ability to stretch, minute tears in the skin around the vagina may occur. During labor, musculoskeletal system is stressed. Diaphoresis, fatigue, proteinuria, and possibly increased temperature go along with the increase in muscle activity. The labor process and the woman pointing her toes can also lead to leg cramps. Euphoria in early labor gives way to increased seriousness, then to amnesia between contractions in the second, and finally to elation and or fatigue after giving birth. Endogenous endorphins raise the pain threshold and produce sedation. Physiologic anesthesia of the perineal tissues caused by pressure of the presenting part decreases the perception of pain. The gastrointestinal motility and absorption of solid foods are decreased during labor. Nausea and vomiting are common. Metabolism increases during labor. There is also a decrease in progesterone levels and increasing levels of estrogen, prostaglandins, and oxytocin. This concludes the lesson on the labor and birth process.